goes. Yes, it is stable angina. So for those just joining us, good evening and welcome to today's discussion. We're going to be taking PLAB-1 Exam CVS and answers. Now, the first question for today was, it's a 3-year-old male who came to the hospital with complaints of occasional left-sided chest pain, which lasts less than 30 minutes, following exercise, then relieves upon rest, right? So what is the most probable diagnosis? Options were of stable angina, decubitus angina, stable angina, coronary spasm, myocardial infarction. And we chose stable angina, and that's the correct answer, right? Unstable angina gets worse over time, but stable angina, when it occurs with exaction, for example, exercise, and then relieves at rest. So that's how you know it is stable angina, chest pain. Okay, so go to the next question. A 9-year-old man with acute renal failure presents with palpitations. His ECG shows tall tinted T waves and wide QRS complex. What is the next best step? 39-year-old man, he has renal failure, right? AKI. And he also has palpitations. His ECG showed tall tinted T waves and widened QRS complex. Classical for something. What is the next best step? Already, keep in mind, patient already has palpitations. So what are you going to do? What's the next thing you are going to do? The question is not asking you about the definitive treatment, asking you what's the next thing you're going to do. So the first thing you need to do is to, first of all, make a diagnosis. What's the diagnosis based on these ECG findings? It's classical for something. What's the diagnosis, Dr. Chara? CARA, as you said, CARA, Abby. Yes, the ECG shows evidence of hyperkalemia, right? So considering that this patient already has palpitations, you want to quickly give IV calcium, 10% calcium carbonate, calcium gluconate. But as calcium gluconate is not here, you can make do with calcium chloride. Because why? Calcium chloride is cardioprotective, right? Just like calcium gluconate. In fact, you give 10 ml of 10% calcium gluconate over 10 minutes. All right. So you now know that, okay, you've protected the heart. Subsequently, you may now have to give IV fluid, 50% dextrose water with 6 units of insulin, 6 hourly, Then you can also use potassium ion binding resins, You can even use salbutamol. These are options. Then finally, when it doesn't resolve, you can do a hemodialysis, an urgent hemodialysis. So all these are options, but this is the immediate. Okay. So the key is B, IV calcium gluconate, both, or IV calcium gluconate or IV calcium chloride, right, can be used when there are ECG changes. Okay. Calcium level of more than 5.5 millimoles per liter, milli equivalent per liter, start having tall tinted T waves, and then widened QRS complexes. All right. A 40-year-old manic depressive noted to have high serum levels of lithium. Remember, lithium is used for treating bipolar disorder, right? So manic depressive means the patient has bipolar affective disorder, all right? Has high levels of lithium, and is one of the drugs that has narrow therapeutic index. So it's prone to toxicity. So patient is found to have profound hypokalemia. His general practitioner has started him on antihypertensives. Choose the single most likely cause. So patient is on lithium, and has high serum levels of lithium, then also has hypokalemia, right? And has been on antihypertensives. So which one will cause hypokalemia? Dr. Kara said it's thiazide diuretic, most likely, because thiazide diuretic, because it will cause hypokalemia, hypomagnesemia, hypochloremia, a lot of hypos, hyponatremia as well. But it tends to cause hyperglycemia, right? Dyslipidemias. So it's thiazide diuretic. Thiazide was prescribed for hypertension, and when lithium was prescribed, its level increased due to thiazide, and thiazide also caused hypokalemia, resulting in the given picture. All right. A 40-year-old man collapsed at home, all right, and died. General practitioners report he suffered from type 2 DM and BMI of 35 kilogram per meter square. What is the most likely cause of death? Has a BMI of 35 and type 2 DM. Collapsed, sudden collapse. So is it a myocardial infarction? Is it diabetes mellitus that killed him? Is it heart failure? Is it pulmonary embolism? Is it renal failure? So the two things that can kill quickly from these options is between myocardial infarction and a pulmonary embolism. All right. And considering this patient has metabolic syndrome, that's type 2 DM, has BMI of 35, which is obesity, right? Grade what? That should be grade 2 obesity, right? Because that's crossed 35. Okay, so, well, most likely, because patient has high cardiovascular risk factors. But the patient is 40 years old. Anyway. Myocardial infarction. In diabetics, myocardial infarction becomes painless when the patient develops autonomic neuropathy. In this case, the disease was unnoticed as it was a painless attack. Just collapsed painlessly and died. So because of autonomic neuropathy, doesn't feel the pain, doesn't feel chest pain, but that's not a good sign. Just like a diabetic that is having chronic leg ulcers and he's not having pain, he thinks it's good that he's not having pain, but that's a very bad sign for that leg. That leg is prone to amputation. The same thing applies here in this question. All right, move to the next. 40-year-old woman suddenly collapsed and died. At the post-mortem autopsy, it was found that there is a bleed from the berry aneurysm from the circle of Willis. In which space did the bleeding occur? Once you see a bleed from berry aneurysm, all right, it's straightforward. This one is a very simple question. It can only be one space. There is subarachnoid space. That's why it's called a subarachnoid hemorrhage. So this patient possibly had a massive subarachnoid hemorrhage, which led to raised intracranial pressure and subsequently led to coning. So it must have been coning that killed this patient, right? Yeah, but let's see if there's any other additional explanation. Subarachnoid hemorrhage is usually the result of bleeding from a berry aneurysm in the circle of Willis. These are called berry aneurysms because of their shape. They're also called circular aneurysm, right? They are once thought to be mostly congenital, but it's now thought to be that the etiology may involve susceptibility of the elastic lamina, right? So when they're exposed to stressors like hypertension, arteriosclerosis, vessels can rupture. Okay, 42-year-old lady had corrective surgery for cyanotic congenital heart disease at the age of 3 years. All right. So I think at this point we need to remind ourselves what are the cyanotic congenital heart disease. Anyway, let me continue with the question. A 2-year-old lady had corrective surgery for cyanotic congenital heart disease at the age of 3 years after a palliative operation during infancy. There is a parasternal impulse and an early diastolic murmur. What is the most probable diagnosis? Parasternal impulse and early diastolic murmur. They've already given you the direction. Yeah. So pulmonary and aortic stenosis are systolic murmurs. Pulmonary and aortic incompetence are diastolic murmurs, are early diastolic murmurs. So I've already given you the answer. This is the diagnosis. Pulmonary regurgitation. All right. So pulmonary regurgitation. Now, there's something like you have to get very good with murmurs because you're going to see a lot of the questions in the exam. And there's something I want you to know. All right. I mentioned it in the last discussion, that was yesterday. Like the locations of the different heart valves in relation to the chest. I know, I noticed it. All right. So in relation to the chest, you have the second intercostal space on the right. That's A. In fact, the code we used to remember is all pray to Mary. That's APTM. So A here is on the second intercostal space on the right. That's aortic area. That's where you hear murmurs that are related to the aortic valve. Do you get? Now, pray, all pray. Second intercostal space on the left parasternal border, second intercostal space on the left, right? That's pray. The pulmonary, whether it's pulmonary stenosis, pulmonary regurgitation, that's where you hear it. That was why they gave you this clue, parasternal impulse. But even without this clue, when you hear an early diastolic murmur, it's pointing towards something. All right. So all pray to. So T is for tricuspid. All right. So the tricuspid area is found on the fourth intercostal space on the left parasternal border. So the fourth intercostal space on the left parasternal border, that's T, tricuspid area. Then the final one is the mitral area. Mitral area, all right, which is found, of course, at the apex of the heart, which is located in normal adults on the fifth intercostal space, mid-clavicular line, right? So all pray to Mary. Okay, so the question said an early diastolic murmur. Now, pulmonary and aortic stenosis will cause systolic murmurs. Then pulmonary and aortic incompetence will cause diastolic murmurs. Okay, so the question said parasternal impulse, then an early diastolic murmur. With this in mind, you always get the correct answer. The pulmonary regurgitation. In the present day, some patients with tetralogy of Fallot has survived for longer than 15 to 20 years after their first operation. The major problem encountered by these individuals is the development of pulmonary valve regurgitation. Remember, we talked about this thing yesterday. You know, part of tetralogy of Fallot is pulmonary stenosis, right? It's one of the components of tetralogy of Fallot. However, over time, the patient has had a repair, but over time, they now tend to develop pulmonary valvular regurgitation. So it appears that a number of these individuals require pulmonary valve replacement subsequently. Okay, so I think that's Makes sense. A 43-year-old lady is admitted with pyrexia, arthropathy, breathlessness, and syncope. Okay, you have a question? All right, go ahead. That should be on the previous question. So what's your question about? If early was removed from the question, what do you mean? Okay, there is a parasternal impulse and an early diastolic murmur. If early was removed from the question, no, diastolic murmur, parasternal impulse. You know, this pulmonary and aortic stenosis are also diastolic murmurs. Hope you know that. There are so many things that made it to suggest pulmonary. First of all, they told you this patient has had congenital cyanotic heart disease, right? So even if you remove an early from that question, it will still point towards this, except if the question is changed entirely. If they want you to point towards this, there are some things they will do that will make it point towards this, because aortic is also parasternal, but it's on the right. So they must give you complete pointers that will tell you that this is the answer. From what I described, aortic area is also parasternal, but is on the right side. All right. But pulmonary area is parasternal, but on the left side. So they are like opposite each other, facing each other on different sides of the chest, on the same second intercostal space. So that's it. If they want you to pick an option, they will give you pointers, clinchers, we call them, that will direct you and make you know, okay, this is what they want me to pick. All right. So remember, we talked about being cyanotic congenital heart disease. Of course, we know that that is likely tetralogy of Fallot, and it comes with pulmonary stenosis normally. So eventually, over time, patients may still develop a pulmonary regurgitation. All right. So that's early diastolic murmur. Like I mentioned, that pulmonary and aortic incompetence or regurgitation cause diastolic murmurs. So it could be pulmonary or aortic. But based on this other picture that they painted here, it is pulmonary. So a 43-year-old lady is admitted with pyrexia, arthropathy, breathlessness, and syncope. She was recently diagnosed with pulmonary embolism. There is an early diastolic sound and a mid diastolic rumble. Her jugular venous pressure pulsation is elevated with prominent A waves. What is the most likely cause? It has layers. That's for symptoms: pyrexia, arthropathy, breathlessness, syncope. All right. She was recently diagnosed with pulmonary embolism. All right. So they've already given you the diagnosis. There's an early diastolic sound and a mid diastolic rumble. Her jugular venous pulsation is elevated with prominent A waves. Now, A waves denotes atrial contraction, if I'm correct. What is most likely cause? It says atrial myxoma. regurgitation, there's ventricular ectopics, there's mitral regurgitation, there's myxoma. You are correct. Anorexia, arthropathy, breathlessness, syncope, and early diastolic sound, and a mid-lick rumble are known features of atrial myxoma. It's a malignancy, actually. I think it's this prominent airwaves that suggested that the source of all this stuff was in the atrium. And the only option in this question that suggested atrium was atrial myxoma. So even if you don't know the entire story, okay. If a 3-year-old lady is admitted with pyrexia, arthropathy, breathlessness, syncope, same question. The same question. A 44-year-old woman has lost weight over 12 months. She has also noticed episodes where her heart beats rapidly and strongly. That's palpitations. Okay, weight loss, palpitations. She has a regular pulse rate of 90 beats per minute. Her ECG shows sinus rhythm. What is the most appropriate investigation to be done? We have thyroid antibodies, we have ECG, we have echocardiogram, we have thyroid function test, we have plasma glucose, weight loss, TFT. Yeah. So you are thinking the patient has thyroid toxicosis, yes. Patient has paroxysmal atrial fibrillation. That is why they are in between attacks. From the given option, thyroid function test is the appropriate test, as thyroid toxicosis is the leading cause of paroxysmal atrial fibrillation. And this lady's weight loss also make thyroid toxicosis as a probable cause. Okay. The 45-year-old lady has 10 months history of shortness of breath. She is found to have irregular pulse and loud B2 with fixed splitting and ejection systolic Momo in left second intercostal space. What is the probable diagnosis? So many ladies are suffering in this question. 45-year-old lady, 10 months history of shortness of breath, found to have irregular pulse, which is atrial fibrillation, right? Then, and loud P2 with fixed splitting and ejection systolic Momo in the left second intercostal space. So that's the pulmonary area now. They're already pointing you in the direction. All right. Atrial fibrillation, loud P2 with fixed splitting, ejection systolic Momo in the left second intercostal space. So what's the probable diagnosis? Tetralogy of Fallot, septal defects, and ventricular septal defects, patent ductus arteriosus, coarctation of the aorta. Ejection, systolic, Momo. Right, so you said it's atrial septal defect. Okay. Diagnosis atrial septal defect with atrial fibrillation. Atrial fibrillation is irregular pulse. Then atrial septal defect gives rise to the shortness of breath, peak splitting with loud P2, and ejection systolic murmur in pulmonary area. This picture is typical. One should not misdiagnose shortness of breath, ESM, and pulmonary area as pulmonary hypertension, though in elderly this can develop with atrial septal defect. So, what really gave it away? Because all these loud P2, fixed splitting. I think this is the clincher here. It's fixed splitting that gave it away. No, irregular was just pointing towards atrial fibrillation. Yeah, but being with that atrial fibrillation, it tells you that the pathology could also be in the atrium. All right, so that's suggestive. But I think it's this fixed splitting because one of the causes was fixed splitting. You know, there's physiological splitting where you have A2P2, right? During inspiration, you have physiological splitting. Then what's the other type of splitting? Before you have reverse splitting, after physiological splitting, you have wide splitting. All right. So after wide splitting, you now have fixed splitting. And after fixed splitting, you now have reversed splitting. So reverse splitting is now the one you see on expiration. So it's usually left-sided pathologies that cause that reversal. All right, left-sided pathologies cause that reversal on expiration. So you have aortic stenosis, left bundle branch block. All right, but wide splitting is caused by right-sided pathologies like pulmonary stenosis, right bundle branch block. Okay, but fixed splitting, I think, is very much specific for ASD. Yeah, and that was what gave it away. That was the clincher. So always ask yourself, what is the clincher in this situation? But let's yeah, I've seen it already, Seth. So wide splitting is seen in conditions that delay right ventricular emptying, such as pulmonary stenosis, right bundle branch block, right? Then split during expiration, that's reverse splitting. It's seen in aortic stenosis, left bundle branch block, hypertrophic cardiomyopathy. Yes. Then split during both inspiration and expiration, that's what you call fixed splitting. All right. It's seen in ASD. Okay, so ASD is very that was the clinical. A 45-year-old man had recently started taking antihypertensive therapy. 6 months later, his Random blood sugar was 14 millimole per liter. What single drug is most likely to have caused this? Was 5-year-old man started taking antihypertensive therapy. 6 months later, all right. Anything more than 11.1 is DM. So what do you think caused this? I gave you the answer in a previous question before. Side effects of one of the antihypertensives. Yeah, bendroflumethiazide, the thiazide diuretic. Thiazide diuretics are known to cause hyperglycemia, hyperlipidemia, right? In addition to hyponatremia, hypokalemia, hypochloremia, hypomagnesemia, but causes hyperglycemia. In addition to dehydration, hypotension, weight loss, okay? So, and so, yeah, it is. A 45-year-old man recently started taking antihypertensive therapy. 6 minutes later, he developed hyperglycemia. Which single drug is most likely to have caused this? 6 minutes later. The other one was 6 months, right? The other one was 6 months. Not the same question. All right. Dr. Shara, you will still choose. So I'm not the pain side effects. Yeah, whether it's 6 months or 6 minutes, it's still the same thing. All right. Amlodipine causes gingival hypertrophy, edema, non-responsive to diuretic, headaches, left ventricular dysfunction, right? Bendroflumethiazide or thiazide diuretics cause hyperuricemia. Yeah, that's one of the side effects as well. It has effects on impotence. That's in addition to the ones that we mentioned before. Dyslipidemia, hyperglycemia, hyperuricemia, right? Hypercalcemia, impotence, the so hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. These are the ones causes hyper. Doxazosin causes dizziness, fatigue, rebound, hypertension, and all those things. Symptomatic orthostatic hypotension, Malay. Losartan causes hypotension, hyperkalemia. Same thing here, except with dry cough, and even has some effects on renal impairments. Okay. For a 5-year-old man who is diabetic and hypertensive but poorly compliant with chronic shortness of, okay, was poorly compliant with medications, has chronic shortness of breath, develops severe shortness of breath, and chest pain. Pain is sharp, increased by breathing, and relieved by sitting forward. What is the single most appropriate diagnosis? So he has a chronic shortness of breath, develops severe shortness of breath, and chest pain. Pain is sharp, increased by breathing. That means it's pleuritic, the pleuritic chest pain, and relieved by sitting forward. So it's classical. We have lung cancer, myocardial infarction. So these are the two options that they want you to get confused with. All right. So this one didn't talk about pain on exertion or pain at rest and all those things. This one was rather talking about sitting forward, you know, and the nature of the pain too is sharp. Pain of myocardial infarction is, how do you put it? It's crushing, all right? So even from the way the person will place his hands on the left side of the chest, you will know that, okay, this is most likely a myocardial infarction. They squeeze their hands, crushing, squeezing, tightening, okay? And it radiates to the neck, the tip of the shoulders, to the hands, to the left arm, particularly, to the jaw, all right? And associated with sweating, some other things, sympathetic hyperdischarge, even sometimes nausea, vomiting, okay? Feeling of impending doom. These are associations of myocardial infarction pain, okay? But pain of pericarditis is pleuritic. That was actually the clincher, all right? It's pleuritic chest pain, and it's also sharp. So, because remember that uh, pericardium is strongly related to the peritoneum and what's the other one? The coverings of the pleura, all right? So they all have a similar embryonic origin. Okay, so anything that affects one tends to affect the others. So when the person is breathing, there's affectation of that stretching pericardial of the pericardium, causing worsening the pain. So it's pericarditis. The sharp, increased by breathing, relieved by sitting forward, suggestive of pericarditis. Okay. 45-year-old manual worker presented with 2-hour history of chest pain radiating to his left arm. His ECG is normal. What is the single most appropriate investigation? He has chest pain radiating to his left arm. His ECG is normal. You know that when a patient has an acute coronary syndrome or angina, depending on the type, there are some types that ECG could be normal. All right, so you want to do some other investigations like angiography. Angiography is not in the options. Then you also want to do a cardiac enzyme, troponin I and troponin T, myoglobins, okay, lactate dehydrogenase, CKMB, CK, all right? So this is point you towards the source of the pathology. So if you have elevated cardiac enzymes, it makes you think about some pathologies. So yes, that's the answer. If a 6-year-old Afro-Caribbean man, that may be the clincher, is found to have BP of hypertensive on 3 separate occasions, what is the best initial treatment? So I told you, that Afro-Caribbean they put there, that's the clincher. So how do you treat hypertension in Afro-Caribbeans? Black man that has systemic hypertension, what's the first line? He's a relatively young man, like the middle-aged man. Yes, it's CBs. But what? Is this it? Ah, the key is ACCB. If age, no, there's confusion here. If A is less than F, mm, why won't you? You have already on 3 separate occasions. I need to make a correction here. The answer is calcium channel blocker. Right, so it must have been lifestyle modification. Say for 6-year-old man with BP of 160/90, that you are doing lifestyle modification does not mean you will not start antihypertensives. You have to start something. On 3 different occasions, you've already made your diagnosis. Assuming this is the first time, you don't have to. That's when you are just giving lifestyle. I'm sure when this GP saw this patient, he just said lifestyle, go and modify your lifestyle, stop drinking alcohol, stop cigarette smoking, and what else? Weight loss, all those things. But what if this guy has a family history, a strong family history? Then he now comes back again. You checked on 3 different occasions, more than 4 hours apart. You've checked, and the BP is still elevated, 160/90. My dear, you have to do something. So it's CCB. This one, don't mind this one, and we have to just correct. The same question again. See, this one is correct now. The same question. So let me give you the algorithm for managing systemic hypertension generally. Okay, so there are 2 arms. In fact, there are like 4 steps. Okay, that's based on the current NICE guidelines. Okay, so if a patient is more than 55 years, it doesn't matter whether it's Afro-Caribbean or anything, the first line would have been AC inhibitor. All right. But if a patient is less than 55 years old, okay, and Afro-Caribbean, let me come again. All right. If a patient is above 55, obviously you are going to start on CCBs, calcium channel blockers. But if a patient is less than 55, your first choice would have been AC inhibitors if the person is not Afro-Caribbean. But if the person is Afro-Caribbean, you go with calcium channel blockers. Okay. Then subsequently, second step, you will now, if CCB is alone and not controlling, you now want to add an AC inhibitor or an ARB. So either of them, you don't use AC inhibitor and ARB at the same time. You should not be using ramipril and losartan at the same time, right? Okay, so you either use one or the other. You should not be using ramipril and what's the other one again? All the satans, valsartan, candesartan, irbesartan. Do not use them together. You can either use one or the other. So, and there's also a preference for diabetics. All right. So if you see a diabetic patient, you want to use ACE inhibitors or ARBs first as first line. Okay. Then step 3, if that is still not controlling the blood pressure, you may want to now add a diuretic. Okay. So that's where you go for your thiazide diuretics and thiazide-like diuretics like indapamide. Okay, that's where indapamide comes in. That's where metolazone comes in, right? So thiazide diuretics from hydrochlorothiazide, benzoflumethiazide, all of them. Okay. Then the fourth line now depends on the the serum potassium level, right? So if your potassium is less than 4, okay, you may want to commence spironolactone. Spironolactone is a potassium sparing diuretic. So if potassium is less than 4, serum potassium is less than 4, you can commence it. But if serum potassium is above 4, you want to now additionally, you don't want to start spironolactone because obviously the patient is already prone to hyperkalemia. And you know that spironolactone triggers hyperkalemia. So that's generally the algorithm. So step 1, step 2, step 3. Just keep adding when you try these. So step 5 now, you can now go to other drugs like beta blockers, doxazothine, alpha beta blockers, you know. So for example, in a patient with chronic kidney disease, you find out that controlling the blood pressure is one of the mainstays of management. So it's not easy to control the blood pressure in a CKD patient. So you tend to use multiple drugs. Okay. If a 6-year-old man with tachycardia has the following ECG, what is the most likely diagnosis? For a 6-year-old man, he has tachycardia, right? Let's zoom into this ECG. Let's look at the leg 2. Look at the leg 2. All right, so P, Q, R, T, regular, P is regular, okay? And they are P waves. They are P waves. What's the, but this P wave is very, 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 very close to the body of the distance. It's almost hiding. It's very, very small. Very small, yes. It's very small. But the rhythm is regular. So that's tachycardia. Let's even count this thing. We'll not be able to see it. So supraventricular tachycardia, ventricular tachycardia. If it's ventricular tachycardia, it will be a wide complex. So the QR complex will be widened, but this one doesn't look wide. Okay. Narrow complex tachycardia is like supraventricular tachycardia. Then heart block, Mobis type 1, where you have PR interval that will be prolonged, right? We're not even seeing the P wave very clearly. Atrial fibrillation, you will have irregular rhythm. Wolff-Parkinson-White syndrome. This is looking like Wolff-Parkinson-White. Because that P wave, the tiny P wave that we are managing to see, is a very, very short PR interval. You're not seeing the screen. Since when now? I've zoomed it. Oh. The tiny P wave I'm managing to see. And this QRS complex looks slowed. There's this, is half, I know, but it's because I'm zooming the screen. Bele. This QRS we are managing to see, there's a slurring. There's this thing we call delta waves. I may be wrong, but that's what I think we have here. So I still think we have something, a very tiny P wave, but the PR interval is very, very short. And in Wolff-Parkinson-White, you can have a tachycardia. I think it's one of the, like a triad. Short PR interval, widened QRS complex. Oh, yeah, we're supposed to have widened QRS complex. Then delta waves. So this should be an SVT. So which one you choose? Is Wolf Parkinson White? Uh, After analyzing, yeah, it is. Okay. Short PR interval, slot, delta wave indicates Wolf Parkinson White syndrome. Okay. Let me show you a normal one. Wolf White syndrome. ECG. Yeah, this one even looks like that. So that slurring was what gave it away, actually. P waves, short, very short PR interval. In fact, that one, the P wave was almost not seen. It's not very clear, sha, but I believe it will be clear in the exam. A 46-year-old woman has weight gain, sensitivity to cold, pulse of 50 beats per minute, heart is enlarged, Momo. What's the single most likely diagnosis? This one is very straightforward now. Patient has bradycardia, uh, cold intolerance, what else? Weight gain. You're still seeing ECG. It will come. It will come. I think your this thing is lagging behind the presentation. Are you seeing it now? Are you seeing what you're supposed to see now? Like the question screen. Yeah, I'm there. Oh. Are you seeing it now? Because you are not replying. Are you seeing the screen? Dr. Chara, this should be the last question for tonight. Anyway, I'll write on so that I'll conclude. If a 46-year-old woman has weight gain, sensitivity to cold, pulse of 50 beats per minute, heart is enlarged with Momo, what's the single most likely diagnosis? Right? Has weight gain, cold intolerance, bradycardia, enlarged heart, that's cardiomegaly. and also has a Momo. Is it hypothyroidism, hyperthyroidism, Cushing's syndrome, Addison's disease, pheochromocytoma? It's hypothyroidism. All right. So the given symptoms are classic presentation of hypothyroidism. Okay, so on that note, then we'll call it a night. Sarah, thank you for coming around. All right, good night.